All right. I'm Dr. Jeff Postma. I'm a board-certified orthopedic surgeon that practices here in Coloma, Watervliet. We're at Community Bone and Joint. A little bit about myself. I'm originally from Holland, Michigan. So the west side of the state is my home. And I live locally in this area. I've been here at Watervliet for a little over 5 years now. Before that, I practiced a little further north of here and came here because of Lakeland and the community here. So what I'm going to talk to you about tonight, and thanks for coming out on a nice evening, kind of our first day of spring. Thanks for joining us. I guess I'm live as well as recorded, so thanks for joining me live. So I'm going to talk to you a little bit about arthritis. What is arthritis? This has been a topic that was asked about to find out what is arthritis. So I deal with arthritis as an orthopedic surgeon. We probably have a little bit different spin on it and what the orthopedist can actually do for arthritis, but it's also what the ability is to enjoy life. Somebody pointed out, I think they recognize the face of Peter Toth. Peter is a patient of mine who had both of his knees replaced, and he was a highly motivated patient because he had to get back to work. He is independent. He sells bread, and he is independent and self-employed. And he did one knee, and then right away was back to get the next knee done and back to work doing his regular work. He considered his therapy pushing carts through the deep snow this winter. So, what is arthritis? Arthritis, the definition is inflammation of the joint. And, when we look at arthritis, there's more than 100 different types of arthritis. So, it's hard to really narrow down the different types of arthritis. It affects 43 million Americans every year. The pain, the swelling, loss of motion to the joint are the things that we don't like. Somebody commented it's a long walk down the hallway with arthritis. That's exactly right. When you have arthritis, you find out that walking any type of distance becomes more difficult when you have that inflammation and swelling to the joint. 1 in 6 Americans are affected, causing a disability with an arthritis of some sort. When we look at arthritis, we kind of break it down into what the most common types are. And I'm going to hopefully try to hit what we most commonly see. The most common one is osteoarthritis. I'm going to tell you it's a little bit more of a wear and tear type arthritis to the joint. We have rheumatoid arthritis. You see a lot of that in magazines. TV ads have really talked a lot about the rheumatoid arthritis, the seronegative arthritis. And this is just how we define it with getting some blood test, in that we have ankylosing spondylitis, and probably the most common one we hear about lately is psoriatic arthritis, because there's now a medication for psoriatic arthritis where there hasn't been in the past. And then the other type of arthritis that we talk about is crystalline arthropathy, crystalline arthritis, and that's gout. There's gout and pseudo-gout, and so we hear probably most commonly about that gout. So before I kind of delve into what arthritis is, we got to understand a little bit about the anatomy and what is affected. So when we look at a knee joint, we look at articular cartilage. That's the cushioning that covers the ends of the bone. We have the meniscus. That's a cushion of cartilage. It's kind of like a little O-ring that's inside the knee joint. And that's another type of cartilage. It's extra cushioning inside the knee. We have the bones, the femur, the tibia, and that's protected by the cartilage. So a normal joint has kind of white, glistening cartilage. When you have arthritis, the damaged cartilage, you have the loss of the cartilage, meaning that the cartilage has become thin or it's worn out. I always describe arthritis to a lot of my patients as tires on your car. You get brand new tires on your car, you have the little nubs on it, you have a really deep tread to it. You drive that car 80,000 miles and the cord starts showing on the tires. And that's what arthritis is. It's that wearing off of that cushioning property. Osteoarthritis is our most common type of arthritis. 23 million Americans are diagnosed annually with osteoarthritis. By 2020, it's expected to be 60 million people annually. So it's a disease that is certainly rising. It's much more prevalent than what it's ever been. And that's part of our baby boomer generation that has the osteoarthritis now. Like I said, the osteoarthritis is a degenerative, and the degenerative is a term that I never really like using. It has such a negative connotation to it. It is a wear and tear of the joint. And all of us are going to have some type of wear and tear to the joint, and there's different progressions of wear that we see. So that's where it could be from an overuse type injury. The hips, the knees, backs, and hands are most commonly affected with osteoarthritis. So the osteoarthritis is a chronic disorder of the joint. It progressively gets worse, and it's a softening of the cartilage and kind of a disintegration, kind of like the car tire wearing thin. It's that cartilage, that cushioning, just constantly thinning. When that happens, the other things that occur is we develop bone spurs on the edge of the bone, and that's sort of our body's reaction, is that our body says, hey, this joint is hurting me, so the body's reaction is to form extra bone around that joint to limit its motion. We don't like that limited motion, but it's sort of the body saying, it's trying to fuse that joint so it doesn't hurt anymore. The bone spurs we call osteophytes. That's kind of the medical term. And just a little sideline with that is that people often ask, can I just remove the bone spurs? And that really doesn't correct the osteoarthritis because you still have that wear to that cartilage, to the cushioning of that joint. So we have several million people that are affected with osteoarthritis of just the knee joint. And it's usually people that are 45 and older. That's with just the ordinary osteoarthritis. There is times that you get osteoarthritis that are due to a trauma or post-traumatic osteoarthritis, and that can occur in younger people. Women are more commonly affected than men for osteoarthritis of the knee. So a couple pictures. This is normal cartilage. This is an arthroscopy, a knee scope. And with a knee scope, we can see the white glistening cartilage, the meniscus that's in the knee. This is what we would normally see and hopefully would see in people. When people have arthritis, you can kind of see the difference to this is that white glistening has now been kind of lost. We actually have bone here. This cartilage here is kind of frayed and what we call fibrillated, has little hairs to it. And that's that thinning, that wearing of the cartilage. The meniscus, right along the edge, gets a little frayed. I always tell people it's sort of like the back of your pants rubbing on your shoe all the time, and that all of a sudden you start getting some fraying to the back of your pants, and that's what happens to that cushion of cartilage inside the knee. So again, osteoarthritis, it's that loss of that cushioning property to the knee. That the cartilage has worn thin or actually delaminated, come loose to rub bone on bone. So primary osteoarthritis means that there's really no known cause of the arthritis. It is just one of the things that can happen. That's what we most commonly see is a primary osteoarthritis. Secondary causes of osteoarthritis is having an infection in the joint. If somebody developed an infection, that can cause a deterioration of the cartilage and lead to an osteoarthritis. There's something called dysplasia. That is an abnormal shape to the bone. Most commonly happens in the hip. It was known as developmental dysplasia of the hip or acetabular dysplasia, or what we called at one time congenital dislocation of the hip. So those things can cause an abnormal mechanics onto the joint of the hip and the knee and cause that undue wear. Trauma, if there was a fracture or a break or some impact onto the joint, it can damage that cartilage and cause it to have a quicker wear. And then avascular necrosis is a type of wear where there's a loss of the blood supply to that joint. Other kind of causes, we always look at, there's a strong genetic component to osteoarthritis, so you can always blame your parents. Metabolic, there's metabolic causes, and that's systemic things, and that's like the infection or diseases that can cause a quicker wear. We relate hormonal changes, a loss of estrogen, postmenopausal, can cause a more rapid change of osteoarthritis. The mechanical properties, if we have changes, one of the most common changes is changes to the foot, where you kind of drop the arch of your foot, you become a little bit more flat-footed. When you become a little bit more flat-footed, it changes the alignment of the knee, causes extra wear on the knee joint or onto the hip joint. And aging, it's a natural process. As we get older, things start wearing out, and that's part of what happens with a joint. So what are the symptoms of osteoarthritis? When you have osteoarthritis, the biggest thing is pain. And then after pain, we see swelling to the joint and stiffness. Those are the things that nobody likes and what causes the most difficulty with walking any type of distance. We can see deformity. If things progress to a point, we can see that somebody becomes more knock-kneed or bow-legged as there's wear to one side of the knee or the other. Instability. People feel a buckling or giving away sensation to the joint. People can have it in their hip. When they stand up, they can feel a catch, and it makes them feel like they have to stop for a second or grab a hold of a counter or a walker. And the same thing in the knee. You can have osteoarthritis of the shoulder that people get when they're trying to lift, trying to put something into the cupboard. Can cause a catch or instability, a feeling of the joint going out. And then the loss of function. That's the decreased ability to walk any type of distance. So when we see a joint like this, this is the outside of the knee joint. That's what we call the lateral side. And this is the inside. We can see that there's a little bit of space here, and there's bone on bone, and actually this bone has actually kind of deteriorated down and has kind of eroded down. So if this person was standing, you would see that they would really be significantly knock-kneed on that side. So osteoarthritis, when we look at the x-rays, a healthy joint has space between. This is where the cartilage is. And if the cartilage is lost, it's bone on bone. And that causes that significant deformity. We actually see some bone spurs that are forming. This type of joint would have instability because the ligaments are super loose on this side and super tight on the other side. So what's the treatment for osteoarthritis? For everything, we can always say you rest it. We change activities. So removing a high impact activity. When you have bone on bone, you really don't want to be the marathon runner and putting that high impact on it. You don't want to be the person jumping out of an airplane, landing on their knees. So you modify your activity for lower impact activities, bicycling, swimming. We use anti-inflammatory medications. That's the Motrin, Advil, Aleve, ibuprofen. There's hundreds of different anti-inflammatory medications. Tylenol. Tylenol works as a pain reliever. Walking aids, using a cane, using a walker. We do physical therapy, exercise. There's injections that we can do, the viscosupplement injections. People refer to them as a gel injection, a rooster comb injection. They're a thick fluid that we can inject into the joint that gives a little artificial cushioning. And then there's steroid injections to decrease the inflammation. When we look at surgical treatment of an osteoarthritis, arthroscopy, doing a knee scope. Sometimes if there's mechanical symptoms, a catching, a locking, sometimes we can go in with a scope, clean things out, and that's essentially all we're doing is just kind of buffing the edge of the bone. We're removing any loose cartilage to try to relieve symptoms. Arthroscopy can help 6 months to a year to help to alleviate pain. It is not, it helps, but it is not kind of the end all. Doing a fusion of the joint. So if you have osteoarthritis to a finger, to a big toe, we actually fuse that joint, remove the joint, and make it a solid piece. At one time, doing the same thing for the knee and for the hip was a treatment for osteoarthritis. A lot of times we can't tolerate a joint that is fused in one position. So our other surgical option is a replacement, doing what we call a total knee replacement or a resurfacing. We remove the diseased ends of the bone and replace it with a metal and plastic component. And I'll talk a little bit about that a little bit later. So the other type of arthritis, rheumatoid arthritis. It's one that we hear a lot about. Most of the time with rheumatoid arthritis, it's bilateral. It affects both sides at the same time. It causes a lot of swelling to the soft tissues. In medical training, we always talk that osteoarthritis is a primary disease of the joint. It affects the cartilage directly. Rheumatoid arthritis and some of the other inflammatory arthritises don't affect the joint directly, but affect the lining of the joint. So the lining of the joint gets extremely swollen, and that fluid that's created from that inflammation of the joint lining causes a deterioration of the cartilage. So it causes joint deformity. I think everybody can kind of point someone else that had the significant deviation to the fingers of rheumatoid arthritis. That's kind of the hallmark sign of a rheumatoid arthritis in the hand. They usually have kind of a uniform joint space narrowing. So if it affects the knee joint, it affects both the inside and outside of the knee joint at the same time. So like I said, rheumatoid arthritis affects the lining of the joint. We actually look at rheumatoid arthritis. What we see, and it's actually kind of funny, in some of the advertisements I've looked at, they list it as it's a destructive effect of TNF, like everybody knows what that is. And it's tissue necrosis factor, or a tumor necrosis factor. So it is one of the elements that cause the inflammation. So with it, that destructive effect, you get bone reabsorption. We actually see a little erosions in the bone. That causes the cartilage to degrade, leads to that joint space narrowing, a lot of joint inflammation, and the joint swelling and pain. So a healthy joint, there's synovium, the capsule that surrounds the knee joint, produces a little bit of fluid that's part of our normal health to the knee joint. But with rheumatoid arthritis, you get this inflammation of the joint lining, causing an abnormal fluid in the joint that causes destruction of that cartilage. So the symptoms, the primary symptom is swelling and stiffness to the joint. Quite often those joints are warm and often very sore to touch. With rheumatoid arthritis, there's a general fatigue that people have. Rheumatoid arthritis is potentially reversible. My colleagues that do rheumatoid medicine are very good in treating this until the end stage. So rheumatoid arthritis affects hands, wrists, shoulders, the neck, knees, ankles, and feet. So it is a systemic. It covers the entire body. When we look at the treatment of rheumatoid arthritis, typically it's started with anti-inflammatories. Those are NSAIDs, the Motrin, Advil, Aleve. And then steroids. They use oral steroids or using an injection into the joint. My rheumatology colleagues had to do a lot towards these drugs, the disease-modifying anti-rheumatic drugs. Methotrexate, hydroxychloroquine, These drugs are, these are kind of the generic names of ones that you'll see advertised, and that they can actually modify the disease and reverse the rheumatoid with those medications. They also look at using other biologics. There's what we call monoclonal antibodies. These two medications are that type of drug. They have drugs that directly affect the receptors of rheumatoid arthritis. So those specialty medications can actually reverse. Yep, I guess I should go back. When we talk about rheumatoid arthritis, to diagnose it, it's seeing a specialist and also getting typically a blood test to find out if that is the type of disease that's occurring. And then it can be treated primarily with the medications. If it comes to the end stage, then we look at surgical treatment. And our surgical treatment is very similar to what it is for osteoarthritis with joint replacement or arthroscopy. Gout. Gout is another really common disease. It used to be known as the disease of kings. Called the disease of kings because of high protein, really rich foods, the thick cream sauces, beer. Those are the things that typically cause an inflammation. Most common area was the big toe. The big toe affected with gout. It's an extremely painful condition. With that, it is the deposit of crystals into the joint. It's called monosodium urate crystals, and those crystals, we can actually diagnose gout by taking a needle, drawing the fluid off. We look at it underneath the microscope, and we actually diagnose and see these type of crystals in the joint. There's two different things that cause the gout. It's either people have overproduction or they can't get rid of the uric acid. My little trivia with uric acid, every time I talk about gout, I always have to talk about the birds of prey flying over and being able to swoop down and grab a rodent. It's because these rodents, when they urinate urate. So they actually urinate uric acid crystals. And we, humans, we break it down so that we don't have the uric acid. But if we don't break it down, it can go into the joint. So the bird of prey is swooping over. Their eyes are polarized, like polarized lenses. You know, if you have a polarized lens, if you turn your head side to side, you get, bright light. Well, these crystals show up in urate. So when a bird of prey flies over, it looks down and it can see the rodent peeing as it's going because these crystals flash back at them so they can swoop down and grab it. I always think that's pretty cool. So that's the uric acid, and that's how we look at it underneath the microscope and to diagnose it. And that's because they don't properly process the purines, and we get this overproduction of the crystals. So with gout, it's usually a very quick onset, severe pain. It can occur in the elbow, it can occur in the knee, it can occur in the big toe. And 90% of the time it's just in one joint. And like I said, 90% of them are in the big toe. It can occur in those other joints. People who are at risk of gout, males are at risk. Postmenopausal females are at risk. Older age, we're at risk if you have high blood pressure. If you're on a diuretic or chronic aspirin use, can put you at a risk. High alcohol use, a high BMI, it's primarily diet. And that's one of the controls, is that, they eliminate the fatty foods, the high iron organ meats, the bad habits of the alcohol, the high purines, the smoked foods can help to prevent or reduce gout. When they have an acute flare, when it's extremely painful, we use anti-inflammatories. Colchicine is a type. Quite often we can do a steroid injection into the joint. The prevention of the disease. We prevent it by finding out if people are overproducers or under-excretors to try to get rid of that uric acid or to reduce the production of it. And the two medications that are probenecid and allopurinol to help correct the cause of the problem. Psoriatic arthritis. So everybody's probably seen someone with psoriasis that is on their elbows or on their knees or on their fingers. That psoriasis is directly affected to a type of arthritis called psoriatic arthritis. With as much TV advertising and magazine advertising we've seen on this, it is really not as common as what it's probably advertised. It's a progressive inflammatory disorder of the joint and, of course, the skin. It causes a bone destruction. It actually reabsorbs the bone around the joint. The classic that we always see on fingers is really significant deformity. We get an x-ray and it looks like a cup with a pencil sticking in the middle of the cup because all the bone is destroyed around that joint. It equally affects males and females. It's associated with, of course, the skin psoriasis. The fingers and the digits are significantly swollen. It's the sausage-type digit that we see with the inflammation. So when we diagnose arthritis, we look at x-rays. The x-rays help determine how severe the joint is. Normally you can't see cartilage on the x-ray. Healthy cartilage, we see the joint space. When we have the arthritic, there's joint space narrowing. Same on the hip. There's normal joint space. And as it becomes arthritic, it's bone on bone. It's the loss of that cushioning inside the joint. So what does orthopedic surgery do with the arthritis? And so we have several of my colleagues that can use the medications to help treat it. And when it comes to the point that it has to be something different, we can offer several different things. There's bracing for a knee joint. The bracing can help put pressure if one side of the joint is worn out. We can put pressure on the joint to kind of try to wear out the other side or use the healthy side of the joint for a while. The problem with that is, of course, you have to wear the brace, and most people feel it's a relatively cumbersome brace to put on, but it certainly can help with the arthritis. We can do arthroscopy, the knee scope. That's making the smaller incisions, washing it out. We can do injections to the joint. And then the final step is doing a replacement of that joint, resurfacing the joint, removing the diseased end of the joint. So when we look at injections into the joint, if there's wear to it, we can do a steroid injection that decreases the inflammation. Decreasing the inflammation will take care of the pain that's within that joint. The problem with a steroid injection is it has to be spaced about every 3 to 4 months. If it's done more frequently, it can actually cause a deterioration of the joint. So that's why it's limited in how often we can do that injection. Another type of an injection is what we call a viscosupplement or a hyaluronic acid, the gel injection. There's several different ones on the market. There's Synvisc, there's Suparts. Those injections, it's 1 to 5 injections that are done into the knee joint. And right now it's limited to the knee joint. Those type of injections can't be done to a hip or to a shoulder just because of how it's marketed with the FDA. But they can give some type of relief to the joint. It can be variable in how it gives relief. Some people have 6 months, 3 to 6 months, up to a year relief with a viscosupplement injection. So cortisone reduces the inflammation. Long term, it can cause damage to the cartilage, so we don't use that long term. Surgical treatment, like I said, the arthroscopy. Benefit of an arthroscopy, it is an outpatient procedure. It is one that we can go through, we can wash out the joint, clean up some of that worn joint. It is probably more limited to a knee joint than it is to a hip. It is done on the shoulder joint also. And then a total joint replacement. That is more of an inpatient type stay. So The arthroscopy flushes out the joint. We kind of wash it out, clean up things. It buys some time with the joint. You know, we certainly look at this as an option in younger people to buy time with the joint. It is not a cure. It's a short-term fix. Unfortunately, it's kind of unpredictable on what our results can be with an arthroscopy. The more mild the arthritis, the more effective an arthroscopy can be in the joint. Kind of the end all is joint replacement or a joint resurfacing. So when do you consider having a joint resurfaced or a joint replaced? It's when conservative things fail. You know, you've tried medications, we've done exercise and weight loss, and you still have discomfort, then it's time to consider that. When we have diminished quality of life, you can't walk the distance that you want to, you can't get in and out of a car very well, getting in and out of a chair is more difficult. Pain that's unacceptable to you. And that is probably the thing that I tell people the most is that, you know, even with a joint replacement, you know, we have our best results if you've had some pain to the joint and it stopped you from doing something. You know, it's an invasive procedure, and you got to know the right time. And people, you know, the person with the joint problem can only tell me when it's time. It's not something that, you know, I can tell you how bad the disease is, and we can see people who have significant changes to the joint and are still able to do things. But when it comes to the point that you can't tolerate the pain, then this is a great option. You have to see an orthopedic surgeon, get x-rays, and you educate yourself about the options. That's what you're all doing tonight, is educating yourself on the options that you have with arthritis. The benefits of the joint replacement, it can eliminate or significantly reduce the pain that someone has to the joint. It enhances the mobility and motion. Our goal is to have the full motion to the joint afterwards. It certainly can improve the quality of life. People afterwards, like Peter Toth, gets back to work, doing the things that he wants to do and has to do. People get back to golfing, people get back to playing tennis. We recommend doing low impact activities after a joint replacement. That's doing swimming, doubles tennis, and those activities can be done relatively quickly right after a surgical treatment. So the joint resurfacing just takes the diseased ends of the joint off. You know, when we talk about joint replacement, a lot of people have the idea that we kind of remove it from here to here and replace everything in between. We keep your muscles, we keep your ligaments in place to try to make it the most natural feel possible. And it's just resurfacing the end of the joint with that metal and plastic component. It can be done on the knee as well as on the hip. We put a new metal socket in place as well as a prosthesis that fits in the bone with a ball that fits against a plastic liner. So the primary components of the knee, like I said, is the thigh bone portion, a shin bone portion, the plastic spacer, and then there's actually a plastic spacer that goes underneath the kneecap. So we resurface the bottom of the kneecap. When you feel it, you still feel your own knee, but that is the back side of it is resurfaced. On the hip joint, there's the pelvis and the thigh bone. The socket, the femoral head, that's where the cartilage is in the hip joint. And when we replace that, you know, that hip, the cartilage is that cushioning property that provides that smooth gliding surface that we have. When we do the replacement, it is a metal socket, prosthesis in the bone, a new metal ball that fits against a plastic liner. All your muscles are left in place with a hip replacement. So the function of the hip is the same afterwards. So success of a total joint replacement, of a joint resurface. There's over 1 million people a year that are having joint replacements. It treats the debilitating disease and the deformity to that joint. We do those right here in Watervliet. Watervliet, we have a dedicated staff and dedicated rooms for our joint replacement unit. All our rooms are private rooms. We use what's considered kind of a joint camp concept in that our physical therapy, our nursing staff, and the physicians all work together to make this improvement, to do the rehab. Very typically with the joint replacements, the stays in the hospital have been reduced. Our typical stay after a joint replacement is 1 or 2 nights after a joint replacement. There is some people that can even tolerate doing a knee replacement as kind of an outpatient, having just a 1-night stay after it with the newer medications that we're injecting to help reduce pain and giving a local anesthetic to that joint. So our OR staff, I work with the same people every day in and out. That is really important with reducing infection and reducing time in the OR and improving our outcome. We use the postoperative pain management of nerve blocks and injections. Most people start their therapy the day of surgery. So you have surgery in the morning, that afternoon we have you walking around in the room already. We try to return to those low impact activities almost immediately afterwards. The golfing, swimming, usually within 1 to 2 months after a joint replacement. There is restrictions, we like to say there's restrictions on high impact activities. We try to limit the running, jumping, jogging onto a joint. When you have a joint that's been replaced, our goal is to keep it for as long as possible. The prosthesis that I use actually can be marketed as a potential 30-year joint, so they can last up to that long, possibly longer. A lot of that depends on use of the joint. Beforehand, we had a discussion on age of replacement, and I've said that we've done replacements on people from the age of 20 to 95, 96. And it depends on the activity level, it depends on how damaged the joint is. Younger, we always have to worry about the joint wearing out and needing a subsequent surgery. But that envelope's being pushed all the time, and it's being done on younger people all the time. So you can always come in for an exam and for a personal evaluation. I have Niambi, she's actually my surgical scheduler. She's here to help schedule appointments if you'd like to have an appointment to see me. We're more than happy to do that. That's at Community Bone and Joint. You can find us on that website. And for more information, you can use this website. Again, thank you so much for coming in tonight and spending your time here. Hopefully I've enlightened you and given you a little bit of information, and I am open for questions. Yes?
When you have arthritis in the 3 joints on your feet, is there anything you can do for that?
Yeah, I have 2 partners that are foot and ankle surgeons, and they treat most of the foot and ankle problems. And depending on where it is in the foot and ankle, there's different things that they can do to help. If it's bracing, using orthotics, or surgical treatment for that. A lot of it, I had mentioned that a lot of surgical treatment for some of the smaller joints is a fusion, and so that's one of the things that they do very frequently for arthritis of the foot.
Is cortisone an option for a hip joint?
It can be. There are studies with the hip joint say that if you do 1 injection to the hip, it works fairly well. And people can get 3 months, 4 months, sometimes 6 months of relief with an injection. The second injection to the hip is about as 25% effective as the first. So that's a significant drop if it's only a quarter of, helps only a quarter of the people afterwards for a second. The hip joint is a difficult joint to get into, and it has to be done under X-ray control to get in, and it has to be done to make sure that you're in the hip joint. They usually inject some dye into the hip joint. So it can be done. It's a more difficult joint to get into. My colleagues that do pain medicine, I have a couple of them that have fluoroscopy, and they are willing to do a cortisone injection to the hip.
Told that they're very uncomfortable doing it because of infections. And my doctor didn't recommend it. That's why I was
So
asking.
there is a little bit higher risk. The higher risk with doing an injection is that if we do a joint replacement afterwards, that causes a higher infection rate. So we don't ever do any type of an injection and then do a surgical treatment. There has to be at least a 3 to 4 month window between an injection and that because of the infection rate. And I had one question right here.
My wrist, I never had it before until 2 months ago, and now I have it in both, and I suffer. What can you do for that?
So, the wrist joint, like we pointed out, the wrist joint, it's common with osteoarthritis and rheumatoid arthritis. With those, it's kind of determining which one it is, if there's inflammation to the joint, if a medication can treat it. We can do injections into the joint. And then a lot of times the surgical treatment is doing a wrist fusion. So fusing that joint so it doesn't move anymore to alleviate the pain.
I always thought arthritis was something that started light and built up, but I got mine all in 2 months.
It can be a very rapid thing also. It's very different. Yes?
I'm having cortisone shock. Can that be put into your feet? I mean, not in your ankles, but my arthritis is in my
Yep.
foot.
Sometimes they do injections into the feet, depending on the joint, depending on the problem that there is.
How about the neck area?
That's not an area that I really work with. I don't do much spine work, but there is injections that can be done into the spine. Depending on where the arthritis is, there is what they call facet blocks that are done.
I'm not even sure it is arthritis, but I had an X-ray done when I was going to the chiropractor, and she said it's arthritis.
Yeah. So sometimes that can be done.
Yeah.
Yes. Back.
Like the gentleman in the middle there, just 2 months ago, my fingers started giving me a lot of trouble, especially in the morning. It makes pissed. Would the first step be to determine whether it's rheumatoid or osteoarthritis?
Yeah, kind of determining which one it is. That's kind of the first step.
Don't they call that trigger fingers?
Well, that can be something different. Trigger finger is a locking of the digit. But sometimes you can have inflammation of the tendon and the tendon lining inside the hand that causes a stiffness to the hand. Most of the time when people have osteoarthritis or rheumatoid arthritis of the joint, we can actually see inflammation. And that's something that, very stiff first thing in the morning, kind of towards the end of the day, it feels pretty good. And then the process starts over the next day. A lot of local things that can be done with that is doing warm soaks. We do paraffin wax baths to the hand in the morning, so that warm wax helps loosen up the joint. I guess that's the best way to say it. Loosens up the joint and helps with that inflammation first thing in the day. I had right here first.
I was diagnosed with arthritis in December, but I'd like to now start going out and doing longer walks. Will that increase the problem if I do that, or?
Not necessarily. Some of with an arthritis is you use it or lose it. So you have to kind of continue with getting the motion and continue with the strengthening. That's where the physical therapy really comes into play, or doing an exercise program, is you maintain that muscle strength around that joint.
So would that increase the pain afterward?
some people it does, but if we do more of a low impact and more of a strengthening program, not necessarily does it increase the pain to a joint.
Does icing do it afterward?
What?
Would
Icing? Yeah, so, I didn't have that in this lecture. People always talk about icing or heat and, which one is better. And it's which one feels better is kind of the big answer. There's two different philosophies. If you have inflammation and you put ice on it, it kind of contracts that blood vessel so you don't have the inflammation to the joint anymore. Icing works really good in the acute setting. So if you walk and you twist your ankle and it swells, you put ice on it. Putting heat on it, heat opens up the blood vessels, increases the circulation to the joint, and washes away the inflammatory cells. So some people get a lot of relief with putting heat. Some people get more relief with putting ice on it. It really kind of depends which one works better for you. Right here.
What is your thinking about stem cells?
I knew that was going to come up. Doggone it. Stem cells. Platelet-rich protein, PRP, are all different possibilities for arthritis at this point. It is considered experimental. There is, clinics that are doing the platelet-rich plasma PRP injections. They actually draw your blood, they spin it down, there's just a small amount of platelets, and that can be injected into the joint. We know that doing this during some surgical procedures can help stimulate the growth, help stimulate some healing. We do it for repairing rotator cuffs, repairing some tendons. There is some studies that are looking at injecting it into a joint to stimulate cartilage from growing. None of the studies have been able to show that there's been any growth of cartilage from those injections. It does have the effect of decreasing inflammation, though. Things change rapidly in medicine. Things change rapidly in this world. Who would have thought he'd be standing there with his phone and, doing it live? We carry more in our phones and technology than what they carried going to the moon. So we see a lot of things changing. We see a lot of things pushing envelopes. There is a lot of other injectables that are being looked at. There's a lot of other surgical treatments that we're looking at of doing corrections. If people have just a focal loss, if I have just a small area of loss of cartilage, that's usually from like a trauma, an injury where somebody had an impact and they sheared off just a small area. Small area is like the tip of my thumb when the whole condyle is like this. I can transplant cartilage cells onto that bone and make that grow cartilage and heal that small contained defect. Now, that's kind of getting out of the realm of what a lot of arthritis is. We can't do that when there's a global loss of the cartilage. But in the future, that may be. The best thing in my bag of tricks right now for arthritis is still the joint replacement. That's what we know relieves things the best. And I think that, the injectables, the chondrocyte injections, the stem cell injections, the PRP injections, they're really being looked at hard. And I think that there probably will be something like that coming out in the future. I don't know when. There's nothing approved by the FDA at this point. I know for a PRP injection, there's a couple clinics around that are more than happy to do it for you for a cost. And I think that is a pretty big fee without the science to back it at this point. There, that's my spin. Let's go right here a minute.
Are there joint replacements for finger knuckles?
Yep, There is. I don't do those. I have colleagues that do hand surgery that do replacements of those.
Are they successful?
Yes. Yeah, they are successful. It's where we have to define expectations. You know, are you going to be, you know, grabbing a wrench and putting force across it with a replacement? No. Does it work to relieve pain? Yes. And maintaining some function. So I had one over here.
What percent of people that have a joint replacement have a rejection issue because of the foreign matter in their body?
So with that metal, there's no rejection of the metal. Where there could be a problem is if people have a nickel allergy. So if they have a metal allergy, you know, you have problems wearing your watch and you break out when your watch, and if you're wearing an earring and always have a rash where your earring goes through, then it's a different type of prosthesis we put in. The different types of metal, and you know, the traditional knee was a cobalt chrome metal, so that's a stainless steel, and it has a percentage of nickel in it. The prosthesis that I use is it's a zirconium oxide, and so zirconium is a metal. When you look at the periodic table of elements, there's titanium. Right below it is zirconium. This zirconium is a really hard metal, and they oxidize. They blast it with oxygen and heat over the end of it. Zirconium oxide is ceramic. So the ceramic is attached to the metal. It's a smoother surface, has no nickel in it. So there isn't a reaction or a rejection with that. Geez, that's a long-winded answer I had right here.
My wrists swell, not all the time, there's no pain. Is that arthritis?
Could be. When there's swelling, there's a lot of different things that can cause the swelling, and without doing a full evaluation, you know, a lot of that is maybe a little bit of guesswork. So I had one right back here. Yeah.
You probably answered it, but I've been told I'm a good candidate for hip replacement. And I guess what I'm trying to get a feel for is, when do you finally do the hip? In other words, I think my doctor is interested in doing it now or sending me to you or somebody. But what urges you to finally do it? Is it the pain or something? Or
Well,
is
you know, first of all,
is it the MRI that's very clear and you just move on?
well, first of all, I don't treat X-rays and I don't treat MRIs. You know, I treat the person attached to those films. So you know, we can determine how bad it is, and that's usually with an X-ray, and that's kind of determining, you know, if there's just a little bit of joint space narrowing, you know, and you're not very uncomfortable, you kind of live with it. If it's bone on bone and you don't have much pain, you might just decide to live with it for a while. But if you notice that every time you get up out of a chair, you have to stop for a second and kind of straighten out, or if you're laying flat in bed and you got to put a pillow underneath your leg because you can't get your leg out straight anymore, or if you know that you can walk, but you're always driving around the parking lot looking for the closest parking space because you know by the time you get to the store, you won't be able to get to the back of the store, then it's time to do something.
Well, you somewhat implied, or at least my impression was, is a lot of the measures, intermediate measures, are short-term. In other words, you're never going to cure your arthritis, so you're ultimately, I'll say, headed toward that replacement.
Yeah, that's probably true, but you know, nobody knows how long it takes to get from that one point to the other point. You know, I have patients that come in and they have some pain to the joint and they just want to know why, and yeah, they have a little bit of arthritis. And then they come back 3 months later and say, this is killing me. And I get an